This may be the first time you have encountered an interactive video disc program in the teaching of a medical subject. Have no fear. It isn't painful, and you may actually enjoy it. One of the advantages of this teaching medium is that the student can control the pace at which the subject is taught and can repeat parts as requested from options shown on the screen in between the main parts of the teaching program. You will be delighted to learn that you can turn my voice off at the second pass should you so wish. The heart sounds and murmurs used in this demonstration are artificially produced by the phonocardio simulator. This gives me a great deal of control in terms of timing, loudness, duration, and frequency of the sounds heard. However, the technology involved is entirely subsidiary to the main aim of this program, which is to help you to auscultate more effectively and with greater confidence. To many doctors, the stethoscope is more of a badge than a tool. This need not be so. The technique of successful auscultation can be learned. It would be foolish to pretend that it comes easily, but by taking this program as the first step, and by following it with perseverance and practice, you'll be surprised how much more intelligible the information coming to you through the guessing tubes will become. We will cover 4 topics in this program: basic cardiac physiology, the normal heart sounds, pathological heart sounds, and finally a selection of the most common cardiac murmurs. The material will be presented to you initially in this order, but subsequently you will be able to review any part of it either during the program or at the end. Before we can hope to understand the cardiac murmurs or even the normal heart sounds, we need to have a clear picture of the normal physiology of the heart. We can best accomplish this by looking at pressure changes in the left atrium, left ventricle, and aorta. Let us begin at the stage in the cardiac cycle where the ventricle is relaxed, the mitral valve is open, the aortic valve is closed. That is, diastole. Blood is entering the left side of the heart, having been propelled through the lungs by the right ventricle. Now let us look at a diagram of the pressures. The left atrial and left ventricular pressures are identical, since the mitral valve is open, and as the heart is filling with blood, both pressures are rising slowly. This passive rising pressure is disturbed when, following atrial myocardial depolarization, indicated by the P wave on the ECG, there is a brief contraction of the atrial myocardium, giving rise to an A wave, which is seen in the atrial and ventricular pressure traces. Very soon after this, there is ventricular myocardial depolarization, indicated by the QRS complex on the ECG, followed by ventricular myocardial contraction. This produces a very rapid rise in the ventricular pressure, resulting in closure of the mitral valve. Mitral valve closure produces a small transient kick in the atrial pressure trace, the C wave, after which the atrial pressure continues to rise along the same passive incline which obtained before the A and C waves occurred. The period when both the mitral and aortic valves are closed and the ventricular pressure is rising rapidly is known as the period of isovolumetric contraction. This period ends when the rapidly rising ventricular pressure exceeds the falling aortic pressure and the aortic valve opens. From this point onwards, blood begins to leave the left ventricle and the aortic and left ventricular pressures are identical. As the blood leaves the ventricle, the pressure rise cannot be sustained. The pressure flattens out and then begins to fall. As the pressure falls in the aorta, the aortic valve closes passively. The period between aortic valve opening and aortic valve closure, that is the time during which blood is leaving the ventricle, is known as the ejection period. The aortic pressure falls slowly as blood leaves the aorta, passing out to the periphery, and the ventricular pressure falls rapidly as the ventricle relaxes. Since the mitral valve has remained closed, both valves are now closed. This is the period of isovolumetric relaxation. Ultimately, the rapidly falling ventricular pressure falls below the rising atrial pressure, and at this point, the mitral valve opens. This marks the beginning of the filling phase. The pressures in the atrium and ventricle are once more identical. Rapid filling occurs initially, and in the normal heart, some 70% of ventricular filling occurs in this initial phase. During the slow passive rise in atrial and ventricular pressure, some 10% of filling occurs, and with atrial contraction, the final 20% occurs. The filling phase ends when the ventricular pressure rise results in closure of the mitral valve. The normal ventricular cycle has 4 phases: ventricular filling, isovolumetric contraction, ejection, and isovolumetric relaxation. The normal heart sounds are produced by valve closure. The first heart sound by mitral and tricuspid, and the second by aortic and pulmonary valve closure. The first heart sound occurs when the ventricular pressure rises above the atrial pressure and the atrioventricular valves close. This marks the onset of isovolumetric contraction and is taken to indicate the beginning of systole. The second heart sound occurs when the aortic valve closes at the completion of the ejection period and indicates the end of systole. The first heart sound therefore occurs just before the upstroke of the carotid arterial pulse, and the second sound just after it. The correct identification of systole is absolutely crucial to successful auscultation. The single most important thing to know about any auscultatory finding is whether it occurs in systole or in diastole. If you are wrong about this, your diagnosis is inevitably incorrect. Without question, the best clinical indicator of systole is the carotid pulse. The carotid artery lies close to the sternomastoid muscle, which runs from the mastoid process to the medial end of the clavicle. The right-handed doctor should place his left thumb just anterior to the sternomastoid muscle, about 2/3 of the way up, and should gradually increase the pressure until he senses the upstroke of the arterial waveform. Events in phase with the carotid pulse are systolic, and those out of phase are diastolic. Since we must accomplish this training program without a real patient, we will show you this carotid pulse marker at the start of each sound demonstration. Now please listen to the heart sounds and watch the display. The pulse pressure rises in association with one sound and falls with another. Now we will remove the display. Listen to the sounds. Can you tell that one is lower pitched than the other? Secondly, can you tell that the one that is lower pitched is of longer duration? Now watch the display. I hope you will agree that the low-pitched, longer sound occurs at the onset of the pulse. This is the first heart sound. The second heart sound is briefer and higher pitched. Please repeat this section if you are unclear about any of the points. Having learned to identify the first and second heart sounds, we can now concentrate on understanding and recognizing splitting of the second sound. The pressure diagram for the right side of the heart is identical to that for the left, except that the pressures are much lower. The second heart sound is produced by closure of the aortic and of the pulmonary valves. If the valves close simultaneously, a single second sound will be heard. If closure is not simultaneous, 2 elements of the second sound will be heard separately. That is, the sound will be split. The aortic component of the second heart sound normally occurs before the pulmonary component. In the normal heart, the degree of splitting varies with respiration. During expiration, the two elements of the second sound are superimposed. As the subject breathes in, the venous return to the right side of the heart increases, the right ventricle fills more, and the right ventricular stroke volume is increased. Because of this, the pulmonary valve closure is delayed. In this normal physiological splitting, the separation of the two elements of the second sound increases with inspiration. This is an example of wide splitting. Lesser degrees of splitting can be recognized with practice. For example, while each of the two elements of the second sound may be recognizable, they may not be completely separated. There might simply be a dip in the loudness between the peaks. During normal respiration, the second heart sound will often be completely closed during expiration, minimally split in early inspiration, and widely split at the end of inspiration. In the presence of an atrial septal defect, wide splitting is audible, and the degree of splitting does not vary with respiration. The second heart sound is one of the most informative features in auscultation, but the appreciation of its subtleties requires a great deal of experience, and the general practitioner need not concern himself with these details. The purpose of this demonstration has merely been to illustrate the kind of information which can be obtained. The third heart sound is a soft, low-frequency sound heard early in diastole, just after the second heart sound. When it is present, instead of hearing lub-dup, lub-dup, you will hear lub-duppa, lub-duppa. The sound is produced in circumstances where very rapid ventricular filling occurs. Its presence is normal in children, young adults, and during pregnancy, and usually abnormal after the age of 40. Abnormal third heart sounds may be of left ventricular or right ventricular origin. A left ventricular third heart sound is best heard at the apex, and a right ventricular sound at the left sternal border. Common pathological causes of a left ventricular third heart sound include pure mitral incompetence, ventricular septal defect, and patent ductus arteriosus. Similarly, a right ventricular third sound may occur in association with tricuspid incompetence. Constrictive pericarditis and heart failure from any cause may give rise to either a left or a right ventricular third heart sound. Let us now listen to an example of a third heart sound. Now identify that the second sound is followed by an additional sound which is softer and lower in pitch, lub-duppa, lub-duppa. This is the third heart sound. Now we will slowly remove the third heart sound and then reintroduce it. Please repeat this section if you are unsure about the identification of the third heart sound. The fourth heart sound is presystolic. and occurs in relation to atrial contraction. So instead of hearing lup-dup, you will hear balup-dup, balup-dup. Fourth heart sounds are always pathological. They occur in situations in which an atrium has to contract more forcibly than normal to fill a stiff or hypertrophied ventricle, such as hypertension, aortic stenosis, cardiomyopathy, and after myocardial infarction. As with the third heart sound, fourth sounds from the left side of the heart are best heard internal to the apex, and those from the right side of the heart at the left sternal border. The fourth heart sound is soft and low in frequency. It is never loud, but is always significant. Okay, let's listen to an example of a fourth heart sound. Check which is the first and second heart sound by feeling the carotid pulse. Now concentrate on the first and listen to the presystolic fourth sound. Balup-dup, balup-dup. It is never a loud feature, and to hear it always demands concentration. Please repeat this section if you would like another try at identifying the fourth heart sound. Note that a third heart sound occurs early in diastole and a fourth heart sound late in diastole. If there is also a tachycardia, the duration of diastole falls, and it becomes impossible to know whether any additional diastolic sound is a third or a fourth heart sound. The combination of a tachycardia and an additional heart sound is known as a gallop rhythm. Now let us listen to a gallop rhythm. There you have it, increased heart rate and an additional heart sound producing a gallop. Of course, although this is universally known as a gallop rhythm, it does actually have the cadence of a canter. Please repeat this demonstration if you feel the need to do so. Murmurs occur as a result of turbulent blood flow. Two conditions commonly give rise to such turbulence. The first is valve stenosis, where blood is forced in the normal direction through an abnormally small orifice. The second is valve incompetence, where blood flows in the wrong direction through a faulty valve. When a murmur is detected, it should be analysed with respect to the following features. Timing. We need to know whether it is systolic or diastolic. In addition, we need to know its precise timing within systole or diastole. Location. We need to know the site of maximum intensity and the directions of radiation, that is, of preferential conduction. The sound envelope. We need to know how the loudness of the murmur varies during the murmur. Frequency components. We need to know the dominant sound frequencies which make up the murmur. We will illustrate these features with specific examples. An incompetent mitral valve allows regurgitant flow to occur from the moment that the valve should close. That is, immediately with the first heart sound. The pressure in the left atrium rises higher than normal because of the regurgitation. Regurgitation continues as long as the left ventricular pressure exceeds the left atrial pressure. That is, until the mitral valve opens. The pressure gradient from left ventricle to left atrium is roughly constant throughout the period of regurgitation. As a result, the murmur begins with the first heart sound, passes through the second heart sound, and is of uniform loudness. That is, it has a flat sound envelope. Such a murmur is called a pansystolic murmur, although it actually occupies a little of diastole as well as the whole of systole. Because of the increased volume and pressure in the left atrium, there will be very rapid filling of the left ventricle when the mitral valve opens, and, provided there is no mitral stenosis, a pathological third heart sound will be produced. The first and second heart sounds tend to be obscured, and we hear a flat, long systolic murmur followed by a third heart sound. Now let's hear the murmur itself. First note that the murmur is systolic in time, synchronous with the pulse. Notice that the sound envelope is flat. The murmur has constant amplitude. The murmur is pansystolic. It is obscuring both heart sounds, although you may just be able to hear the second sound at the end of the murmur. Now I will remove the murmur by turning down its amplitude and then restore it to its full volume. Perhaps you can now identify the hint of the second sound. Now we will listen to a pansystolic murmur with a pathological third heart sound. The third heart sound is often mistaken for a second sound. The first and second sounds are in fact obscured by the murmur. We can demonstrate them by removing the murmur. Now you can hear the three heart sounds. I'll return the murmur to its former loudness. So remember, when you hear a flat pansystolic murmur, followed by a gap and then a heart sound, the heart sound you hear will be a third heart sound. No condition exists which gives rise to a flat, long systolic murmur which stops just before the second heart sound. So you can be quite sure that it is a third sound which you are hearing. Please repeat this demonstration until you are confident. A stenotic aortic valve produces turbulent flow during the time that the valve is open, that is, during the ejection period. The murmur thus begins distinctly after the first heart sound, which is therefore not obscured. The aortic pressure does not rise as high as the left ventricular pressure because of the narrowing at the aortic valve. The pressure gradient from left ventricle to aorta rises during systole, and the murmur therefore has a triangular shape. The second heart sound is often diminished because the aortic valve is frequently calcified in middle age. A triangular-shaped murmur occurring during the ejection period is referred to as an ejection systolic murmur. We will now demonstrate this murmur. First note the murmur is systolic, in time with the pulse. The murmur has a triangular sound envelope, increasing to a peak intensity, then decreasing rapidly. Now listen carefully to the second heart sound immediately after the murmur. To make this easier, we will turn down the amplitude of the murmur and then restore it again to its initial level. Please repeat this section until you are confident that you understand it. Diastolic murmurs are rarely loud, easily missed, and always important. They are recognizably diastolic by virtue of being out of phase with the carotid pulse. Diastolic murmurs are divided into early or immediate diastolic murmurs, mid-diastolic murmurs, and late diastolic or presystolic murmurs. An early or immediate diastolic murmur is one which begins immediately with the second heart sound. A presystolic or late diastolic murmur is one which continues up to the next first heart sound. A mid-diastolic murmur is one which begins recognizably later than the second heart sound and ends recognizably before the first heart sound. It need not, therefore, occupy the mathematical middle of diastole. When the aortic valve is incompetent, the aortic and left ventricular pressures rise higher than normal since the left ventricular stroke volume is increased. The aortic pressure follows the left ventricular pressure precisely during the ejection period. During diastole, the aortic pressure falls much lower than normal because of the aortic reflux. Retrograde flow through the valve begins with the second heart sound and gives rise to an early diastolic murmur. We will now listen to an example of this murmur. First, identify the first and second heart sounds. Immediately after the second sound, you can hear a high-pitched, soft murmur. It begins with the second sound. You cannot separate them. Therefore, it is an immediate or early diastolic murmur. The fact that the murmur exists demonstrates that the lesion is present. But remember that the loudness of the murmur is not a reliable indication of the severity of the lesion. Stenosis of the mitral valve gives rise to a gradient between the left atrial and left ventricular pressures when the mitral valve is open. The induced murmur follows the gradient and occupies mid-diastole. If the stenosis is mild, pressure equilibration occurs and the murmur ceases, becoming apparent again in presystole when the atrium contracts. Mild mitral stenosis in a patient in sinus rhythm then gives rise to a mid-diastolic and a presystolic murmur. Let us listen to an example. Identify the first and second sound by referring to the pulse. Note that the murmur is out of phase with the pulse, that is, it is diastolic. Since there is a gap between the second heart sound and the onset of the murmur, and between the end of the murmur and the next first heart sound, the murmur is mid-diastolic. In mitral stenosis, the first heart sound is accentuated. Let us listen now to the combined effects of the murmur and the accentuated first heart sound. There is also often a loud sound called an opening snap associated with the murmur. Let us listen to the effect of adding this in. There is also often a pre-systolic crescendo murmur associated with atrial systole. Let us listen to the pattern produced when this is added in. We need to recall two further things. The first is that if the stenosis is severe, there will be no gap between the mid-diastolic murmur and the pre-systolic murmur. The second is that in the presence of atrial fibrillation, not only is the ventricular rate irregular, but atrial contraction is lost. Pre-systolic accentuation of the murmur will therefore not occur. Please repeat this section if required. We spoke earlier of the four features requiring analysis in the assessment of any murmur. These are timing, location, sound envelope, and frequency. We have so far considered the timing and the sound envelope. We must now consider the frequency and location of the murmurs. Although loud murmurs are often audible all over the chest, each lesion tends to be associated with a position at which the murmur is loudest. In addition, there are often areas of preferential conduction of the sound from the site of maximum intensity. These directions of preferential conduction are known as directions of radiation of the murmur. Thus, mitral incompetence gives rise to a systolic murmur, which is loudest at the apex of the heart and which radiates into the axilla. Aortic stenosis gives a systolic murmur maximal in the aortic area and radiating along to both sides of the neck and to the apex. Aortic incompetence gives an early diastolic murmur, best heard in the aortic area and down the left sternal border. This murmur is so soft that it is easily missed unless conditions are optimal for its detection. The patient should be asked to sit up, lean forward, and hold the breath in full expiration. The diaphragm of the stethoscope should be held firmly over the aortic area or left sternal border. Mitral stenosis gives a mid-diastolic murmur with, in the presence of sinus rhythm, pre-systolic accentuation. The murmur is often precisely localized to the apex and may easily be missed. The patient should lie on his left side with his left arm moved out of the way. The location of the apical impulse should be identified and the bell of the stethoscope applied accurately to the spot. A ventricular septal defect gives rise to a murmur which is virtually indistinguishable from that of mitral incompetence, except that it is best heard at the left sternal border and it does not radiate to the axilla. Most murmurs have a mixed range of frequencies, and it does not matter whether the bell or the diaphragm of the stethoscope is used. The diaphragm produces louder sounds, but the bell gives better apposition to the skin if the chest is bony. Two murmurs have relatively narrow bands of frequency components: aortic incompetence, which has predominantly high frequencies, and mitral stenosis, which has predominantly low frequencies. Aortic incompetence is therefore best detected with the diaphragm, and mitral stenosis with the bell. Auscultation is a very difficult art to acquire. Most doctors receive inadequate training and inadequate experience in the technique. In the hands of a skilled observer, auscultation provides a wealth of useful data. The key to success in auscultation is a disciplined approach combined with concentration in answering one question at a time. Understanding the normal hemodynamics of the heart and the hemodynamic changes induced by disease greatly facilitates the acquisition of satisfactory auscultatory techniques.